Hello, everyone, and welcome to Doctor On Call on Catholic 540 AM Divine Mercy Radio. I'm your host, Ellen White. I'm thrilled to be continuing our conversation with Dr. Patrick O'Connell. And for those that have missed our previous episodes, Doctor On Call is a once-a-month discussion on current medical topics, with Dr. O'Connell's practical medical advice from a Catholic perspective. So listeners, take advantage of this awesome opportunity to have your medical questions answered for free. Write to us at info@catholic540am.org with any medical questions you'd like to have the good doctor answer. We really enjoy the Q&A segments of the show. Such a great way to get connected with you and your concerns. And for those that don't know, Dr. O'Connell has been practicing medicine in the Raleigh area since 2006, joining Duke Health as a primary care physician, and in 2017 founded Sentinel Primary Care. Dr. O'Connell has a certification in Catholic healthcare ethics from the National Catholic Bioethics Center. Dr. O'Connell is an underwriter of Divine Mercy Radio. Good afternoon, Dr. Pat.
Good afternoon.
So for the next 3 shows, we will be covering end-of-life care. And for this show, we'll discuss ordinary versus extraordinary care. Our next show will cover the legal documentation and healthcare planning. And finally, our last show on end-of-life care will cover organ donation. So Dr. Pat, before we begin into defining the terms and the subject of today's interview, ordinary versus extraordinary care, I'd imagine our definition of pain has changed over the years. Would you agree?
I agree. I think, it's something that I think for lots of people was just kind of part of normal everyday life and being on the earth. And essentially, as healthcare has gotten a lot better, it has become less a part of routine life for many people. And so I think there's been a shift in the view of pain. As like, I would imagine previously it would be, yep, this just goes with the territory, you can't avoid it. And now I think the perspective is you can avoid it and it's horrible and it is to be avoided. So I think there's sort of a cultural shift over the decades with this.
Yeah, right. Okay. And how would you define, and these were new terms to me when we first started discussing this about a year ago, but how would you define ordinary versus extraordinary care? And I know that is sometimes related to proportionate versus disproportionate care. So take us through all of those words and what they mean.
Yes. Yeah, so these are really important terms to define or just to kind of understand the idea of it. So the idea is if someone is considering some medical treatment, whatever it may be, a course of medicine, a surgery, a chemotherapy regimen, whatever. The idea is, or the question at hand is this something that I need to do? Like, am I morally obligated to do it in the course of just taking care of myself? Or is it something that's maybe an optional treatment? And so the language that has grown up around this, the original language was ordinary and extraordinary. The implication being care that was ordinary didn't mean like, oh, that's boring, that's nothing. It means this is just part of the regular ordering of taking care of yourself. Like, this is just something you do. That's ordinary care. And then extraordinary was meant to mean care that would be beyond just the regular stuff that you do, that there's something to this that makes it above and beyond, and therefore that would make it an optional treatment. So that's all fine, but as the use of language evolved over the years, ordinary kind of came to mean more a sense of like, that's boring. And extraordinary is like, ooh, that's super snazzy, cool, latest technology. That's extraordinary. But that's not what the terms ordinary and extraordinary mean. So then bioethicists came up with parallel terms that mean exactly the same thing, but meant to just convey the meaning a little clearer, which is proportionate and disproportionate care. And the idea is that care that a person would judge as proportionate means this is care that I need to choose, I need to do it. And care that's disproportionate means something about the burdens of it are disproportionate. And therefore it becomes an optional surgery, an optional medicine, an optional chemotherapy, for example.
Mm-hmm.
So ordinary and extraordinary mean the same as proportionate and disproportionate.
Gotcha. Okay. So moving into understanding the difference between the two in the event that you are struggling with an illness that requires treatment, and you're trying to balance the two. I understand that the ratio of benefit to burden of treatment can vary widely. Ordinary treatments becoming extraordinary, for example, as a particular illness progresses. What would be some specific examples of excessive burdens? Or
yep. So in thinking through this, the process of it is the person who is trying to figure out, should I go forward with this surgery, for example, has to weigh out the benefits of the surgery versus its burdens, versus its downsides, and weigh those out. And it's very much a individualized decision making. There's not a given surgery, for example, that is always going to be proportionate or always going to be disproportionate. So it very much depends on the particulars of the individual, the particulars of their situation. And so cognitively, that process, and from a discernment process, the way that it would work is the person looks at the benefits on the one hand, and benefits are going to be, well, how likely is it that this surgery will succeed? And how big of a success am I going to get? What am I getting out of it? What's the benefit that comes if it's successful? So that's the benefit side. And then the burden side is all the things that are the downsides. So the immediate obvious downsides of like, well, shoot, it's surgery. There's going to be recovery and pain and maybe a phase of debility while I'm recovering from the surgery. And there's going to be the cost of the surgery. And so there's all these considerations on the burden side. And so the idea then is the person has to look at these, think them through. It's a cognitive process and it's a spiritual process. So then also in prayer, turning to God and saying, in the course of taking care of the life that you have given me, guide me. Should I do this? Should I not? So it's an intellectual process and a spiritual process of discernment. And so then if, you were saying how these can vary widely. So one scenario might be, I'll stay with surgery. So a major surgery with a 50-50 chance that it cures some terrible condition. Say a person has some potentially disastrous blood vessel abnormality, an aneurysm, that if it ruptures, they're going to die. And there's a potentially life-saving surgery, but it's a big surgery. And so that person might say, well, shoot, this aneurysm is really dangerous and it is threatening me, so I'm going to go forward with the surgery. Another person might say, well, the recovery from the surgery, I don't know that I'll ever get back to where I was before. And in the near term, I have these incredibly important caregiving obligations. Say a person is a caregiver for their spouse who is debilitated at the end of life, and they need to be the caregiver for them. And the person says, well, if I go through surgery, I can't be my wife's caregiver. So therefore, I'm putting off this surgery. So those would be two different scenarios where the scales would tip in opposite directions. And then as the situation unfolds, the assessment may unfold. So the person's spouse recovers and now no longer needs care. So the person says, well, great, now I can go through my surgery and go through my recovery. And now it becomes proportionate and therefore something the person goes forward with.
Wow, yeah, it makes so much sense, and it's so good to have the information under benefits of treatment and the information under the burdens of treatment, and being able to think about them and pray through them and really weigh them out and see if it's balanced and making a decision. It's so clear cut. I imagine when you're in the midst of situations like this, though, there's so much emotional energy that comes to play with the families and So I know that our next show is going to talk about legal documentation and how important it is to have this set ahead of time so that our emotions aren't running us in a direction that we really don't care to go. So it's so interesting, and it's not a one size fits all approach.
Right, right. Yeah, so a given treatment that in one set of circumstances a person might judge as proportionate, like, okay, got to do it. This is my obligation in taking care of myself. Change the circumstances and, hey, you know what? This is now disproportionate. This is optional. Like, maybe I'll choose to do it, but maybe I won't. And that's okay.
And I imagine too that as it gets further on with some procedures, I mean, you might decide, okay, yes, it is worthwhile to get this surgery. You've weighed everything and you've prayed about it. And then something happened with the surgery and it gets prolonged. And then you realize that another surgery or some other form of treatment is not going to be in the best interest. So you decide not to go further. So it's a step-by-step process, I'd imagine.
Yep. Yeah,
okay.
exactly.
Let's talk about, unless there's something else you'd like to add with that, let's talk about nutrition and hydration.
So one thing I will add, just to spell out in a way that I think breaks it down into useful bites for listeners, is in two things, actually, I would say. So the first one is there is to avoid a pitfall that's so easy to fall into, which is when considering the next treatment, the next surgery, the next chemotherapy, there's a temptation to say, I'm too sick, or my situation just stinks so bad because of my condition, I don't want to treat myself anymore. Or I'm responsible for my uncle and his care. His quality of life is so poor that we're going to stop. And that's a major pitfall. It's maybe a little more depth than I can go into to explain why that's not a great approach. But the foundational starting point when weighing out proportionate and disproportionate, the foundational starting point always has to be that life is good. Life is a gift from God. And even when the tangible qualities of life are admittedly lousy, life is still good. That person with advanced dementia, with terrible pain, with whatever the issues may be, in exactly that state, that's the person that Jesus died on the cross for. And so their life, even at that moment, has surpassing dignity. Even when they can't wipe their own bottom, they have incredible surpassing dignity. So that always has to be the starting point. So then the consideration is not, is this person's quality of life such that we're not going to treat them? Instead, the decision is the treatment itself too burdensome or not? And therefore, are we going to go forward or not go forward with treatment? So that's such an important distinction. And then to spell out benefits on the one hand and burdens on the other. So Catholic moral theologians have really kind of dug into this and tried to make it practical. So some practical pointers on the benefit side. The couple considerations are the likelihood that the treatment's going to work and the magnitude of the benefit. And then on the burden side, the list is going to be side effects. That's a clear burden. Cost is a clear burden. Interference with other duties. So if a person has other responsibilities that they're not going to be able to fulfill if they do this treatment, that becomes a burden of the treatment. If their treatment is burdensome to others, that's a consideration.
Well, let me jump in on that, because I think, and you were talking about suffering and dying with dignity, and we're talking about it from the patient's perspective. What about the caregivers that get grace from serving others? I mean, you deny, I'm really big on that, especially with my kids when they're serving me. No, I'm kidding. But when, when you deny someone the opportunity to serve you and they are receiving grace because of that and growing in love, and I mean, there's so many different things that are associated with that. So
right.
I think that's a big deal to touch on.
Yep.
And you touched on excessive costs of treatment and how that can be considered as a valid reason for foregoing treatment too.
Yeah, absolutely. Yeah,
Okay.
we're not obligated to bankrupt ourselves in the course of taking care of ourselves.
Right, right. Wow, there's so many great things to ponder as we make these decisions moving forward. Okay, let's talk about nutrition and hydration.
Yes.
And I also want you to touch on too those individuals that were cared for that were in comas for years, and everybody kept saying, pull the plug, they're not going to, and they end up waking up. There's one story in particular that I heard about. There was I don't remember the particulars of the case, but he was in a coma for 18 years and his wife took care of him. And the doctors kept saying, no, he's not going to survive. You just need to pull the plug, let him die. And he woke up and he heard everything that was going on in the room with family members and getting married, and recalled specifics about the relationship. So I thought that was fascinating. How often does that happen?
So admittedly, it's rare.
Okay.
When someone has such severe neurologic injury that they're unconscious for a prolonged amount of time, it's probably going to stay somewhere in that arena for the long term. So cases like that are remarkable, but they are also, yeah. So it happens, but it's so uncommon that it's newsworthy. So it's a rare occurrence that someone should recover especially in that dramatic of a fashion. You can have some improvement in neurologic function, but if there's been really bad brain injury, then a lot of that's not recoverable, unfortunately. So then the issue arises, well, what about food and water? And especially, what if the person has such a neurologic injury that they can't feed themselves? What do you do? And so if listeners may remember Terry Schiavo from late 90s, early 2000s, this long drawn out court fight and sort of a cultural battle as well. And what the fight centered on was artificially feeding her through a feeding tube and whether to remove the tube or not. And of course, at the end of this long drawn out fight, her feeding tube was removed and then she died, not from her neurologic injury, but from dehydration. So after that, it ties into this big question about, well, what if I need a feeding tube for my ongoing hydration and ongoing nutrition? And where does that land in this whole arena? So what came out of the whole knockdown, drag out fight culturally and legally with Terry Schiavo is actually the US bishops wrote to the Congregation for the Doctrine of the Faith and said, we just went through the ringer culturally in the US. Can you give us some guidance on this? Because we have theologians who are on different sides of this. And the congregation sent back a one-page document that said very clearly, artificial nutrition and artificial hydration, meaning using a feeding tube, are to be considered essentially proportionate and therefore obligatory until proven otherwise. So, we talk about kind of this balance of weighing out the benefits and the burdens, but essentially what they said is, no, in this case, the scales come pre-tipped. The scales already tip towards benefit. So therefore, feed the person, unless there's some very compelling reason that tips the scales back towards burden. So it's a very useful and clear statement coming from the Congregation for the Doctrine of the Faith.
Wow.
And so what that translates into then is if a person is in a prolonged coma and, if you don't put in a feeding tube, then they're going to die of dehydration, then the obligation is feed the person. So we should consider food and water as ordinary or proportionate care. This is stuff we do until there's some very compelling reason not to. And that compelling reason would be, again, in the burdens list, like there's some technical problem where putting in the feeding tube, there'll be some terrible complication and there'll be something bad that happens, or, the person has enough cognitive awareness, they keep yanking the tube out and now we have to restrain them and use sedating medications. And now we're introducing more and more burdens, more and more downsides. Maybe then the scales tip back in the opposite direction, but the starting point is yes, food, yes, water.
Okay. Yes, food, yes, water. And, I'm constantly reminded about the different levels that you have to keep asking yourself these same questions about whether or not it's proportionate, disproportionate care, and taking everything into consideration. It's really fascinating.
Yeah.
All right, and I wanted to back up a little bit and talk about an experience that I had, and a kind of a comment and a question with that, and then dive into some listeners' questions that we've got and on the subject. I had an experience last year with my aunt. She was dying. She was close to death within, a few weeks, had cancer and only a few days to weeks left to live. And my brother and I, thanks be to God, were able to spend some time with her. And she wanted to go 6 months before that. She had no desire to live anymore, but she had a son that was in the medical field, and he is a strong Christian, and he refused to provide medication or anything that would shorten her life. So I don't think that there was any legal documentation to the effect. But my question with this is, and there was some concern with my ignorance with morphine and what that does. She with levels of morphine, can that speed the process? I know that's not the right term, but if someone is desiring to die, if there are levels of morphine that are high enough, will that make you die faster?
It could. It could. Morphine will suppress the drive to breathe. And so an excessive dose of morphine or similar pain medicines, then the person may stop breathing. So yes, it could hasten death.
Okay. Wow.
Now, as a point on that, so you could use morphine in two morally totally different ways. So one would be a person who is in great pain as they're dying of, say, a cancer, and you use adequate morphine to relieve the pain, but as a consequence, the person is kind of semi-conscious and their breathing is suppressed, and perhaps as an unintended consequence, their breathing stops and they die. You didn't intend for that to happen. You intended to relieve their pain, but as an unintended consequence, they died. That can be acceptable. That can be appropriate. Or you can use morphine very differently to say, I'm going to use this in order to suppress respiration so that the person will die, so that they will stop experiencing pain. And that's euthanasia. So on just the material level, those two actions look identical, but on the moral level, they are worlds apart.
Is there a dosage amount with the morphine that, okay, you've gone too far and this is going to suppress breathing? Or
it's going to depend on how much morphine the person is used to receiving.
Okay.
So the more someone has been receiving morphine and similar medicines, the more they kind of compensate for it from a respiratory standpoint. So they may be able to put up with doses, so to speak, that if I took it, 5 minutes later, I'd be laying on the floor, not breathing. And it's a customization process.
I see. Okay. I really hope I'm able to be conscious at the end of my life, really, because I want to be able to pray, to receive the sacraments, and to heal any relationships that need to be healed. I really hope that I'm conscious of that. All right. Do you have?
It's so interesting. There's this. Back in 1950s, I think it was Pope Pius XII was talking about exactly this issue of using medicines for pain relief that could suppress consciousness. And he said, if you have fulfilled the responsibilities of that are at hand, and now pain medicine will suppress your consciousness, it's okay. So it's fine to do that. But your point's exactly right that, I still have a relationship that I haven't fixed, and my brother's coming into town tomorrow, and this is it. This is our last chance to reconcile. All right, let's hold off the morphine. I'm going to put up with it so that I can see him and reconcile.
Yeah. Wow. All right. So if you don't have any final comments on that. We'll move to questions, or okay. All right. So a question from a listener is regarding tube feeding. Is it considered something you would be required to give or provide, or can a patient choose to refuse food and die naturally?
So yeah, this goes to the guidance from the Congregation for the Doctrine of the Faith. So the starting point is, yes, food and water are obligatory, but circumstances could arise where the burdens of delivering that food and water become so great that it could become disproportionate. But your starting point is to say this is proportionate and this is therefore morally obligatory.
Okay, and I think this is more of a comment than a question. Do you, Dr. O'Connell, believe that the current trend is towards disrespect of life?
Absolutely.
Yeah.
Unfortunately.
Unfortunately.
I mean, life is, this has been a trend for a long time, but is quite strong now, where, you know, it goes to that quality of life and value of life, that we will regard life as valuable and good if, and fill in the blank, if it meets some criteria that I set of enjoyability, physical enjoyment, capacity, intellectual ability, whatever criteria you want to put in. Unfortunately, we increasingly are putting the if there, that life is good if. So it's conditional. It's like, it's good if I decide it's good. And that has disastrous consequences, unfortunately. I mean, because ultimately, everything in this life, everything is ordered towards heaven. Every moment of life, whether it's, oh, this is an awesome day on the dock fishing with the sunset and the birds, and that's ordered towards heaven just as much as the worst, most miserable day of my life is also ordered towards heaven. And so when you see it in that light, suffering, I mean, we're crazy Catholics. We think suffering can have redemptive value. Well, yeah, it sure can.
It sure can.
So we essentially, I mean, not to seem silly about it, but if we hitch our wagon to Jesus, he pulls our suffering along, and, you know, we join him on the cross. I complete in my own body what is lacking in the sufferings of Christ. And so everything in this life is ordered towards heaven. That's our home. That's our ultimate destiny.
You know, you touch on something too that, and I want to bring in Mr. Letty. The last time I interviewed him, I asked him to give some final thoughts at the end of the interview, and he said, parents, we need to teach our kids to face their fears. And once they face that first initial fear, they're going to be stronger to face the next fear, and then it grows and it grows. And I think that can really relate to suffering too. You know, when we face that little inconvenience, that little gnat that's driving us crazy as it's flying around our head, and we're able to, you know, I know that that's a simple explanation, but I think if we do that with our suffering, it's a lot easier to suffer greater with the next step, and greater with the next step. So, and I think that that's what we experience in this world, right? We're tested constantly. So that's beautiful. Okay. And I wanted to say too that I wrote, and I'm going to date myself, 30 years ago, I had an English writing class in college, and I wrote about euthanasia and, you know, being against it and why. And I'll never forget, the professor wrote on the cover of my paper, my mother is dying. She's got a terminal illness. Where is her dignity? And that was the first time I heard that question. And that was 30 years ago.
Right.
So, and as a medical professional, I'm sure it's a challenge for you.
Right.
Yeah. Okay. So last question here. How do we give care to minimize pain and suffering without causing the death by overdose or having the organs fail due to medications? It seems palliative care is close to euthanasia, like you just said.
Yeah. So essentially, it's how hard do you want to push on the pain relief if the increasing doses of medicine are beginning to cloud consciousness and suppress breathing and make it to where the person can't eat and drink and they get dehydrated and cause other problems. Like Pius XII had said, you can legitimately, in the right circumstances, use medications to relieve pain and suffering, even if it shortens the person's life. That can be okay. So the message isn't, oh, you've got to feel every bit of the pain here until the last minute. But a person may choose, or the person giving the care may say, you know what, let's back off a little bit on the dose so that I can remain conscious, so that I can continue to interact with people and continue to pray and be cognizant of what's happening. Yeah, so it's a question of how hard you push with the medications.
Oh, great topic for today. Disproportionate and wait, I'm not saying that right. Great topic for today. Ordinary versus extraordinary care.
Yes.
And any final thoughts as we wrap this up, Dr. O'Connell?
So this weighing out of benefits and burdens, and therefore proportionate and disproportionate care, can be taxing emotionally. When you're confronted with it yourself or on behalf of someone you're responsible for, it can be so incredibly emotionally taxing. So it's one where I would say to folks, if you're in that situation for yourself or for a loved one, to turn to others for support, turn to people for counsel, because it's a tough time.
Okay, and well, it's a great segue to our listeners that might not necessarily have a Christian or a Catholic physician that they're dealing with. Where can our listeners go to find you?
Yes, so my practice, which is a Catholic practice, is Sentinel Primary Care. sentinelprimarycare.com is the web address, or you can just Google my name, Patrick O'Connell.
Okay.
Actually, one other resource I'll say, if for listeners, if you're stuck in a big dilemma, you're like, oh my gosh, I don't know what to do. The organization, Ellen, you mentioned at the beginning, the National Catholic Bioethics Center, has a consultation line where you, as a person in dilemma, you can call them and say, here's the situation I'm facing in taking care of my mom. I don't know what to do. Can you help me? And they can give moral guidance in that weighing out process.
Okay, say that again. National Catholic Bioethics Center, right?
Correct.
Okay, good. All right. And Sentinel Primary Care for Dr. O'Connell. Listeners, yes. Stay well. You're in our prayers. And should you have any questions for Dr. O'Connell for our next show, please email us at the station at info@catholic540am.org. This recording of this interview today is done on St. John Paul the Great's feast day. And in light of that, I'd like to end with a prayer that St. John Paul the Great composed, asking for Padre Pio's intercession in the midst of suffering. Teach us, we ask you, humility of heart so that we may be counted among the little ones of the gospel, to whom the Father promised to reveal the mysteries of his kingdom. Help us to pray without ceasing, certain that God knows what we need even before we ask him. Obtain for us the eyes of faith that will be able to recognize right away in the poor and suffering the face of Jesus. Sustain us in the hour of the combat and of the trial, and if we fall, make us experience the joy of the sacrament of forgiveness. Grant us your tender devotion to Mary, the mother of Jesus, and our mother. Accompany us on our earthly pilgrimage toward the blessed homeland, where we hope to arrive in order to contemplate forever the glory of the Father, the Son, and the Holy Spirit. Amen. Thanks for tuning in to Dr. On Call on Catholic 540 AM Divine Mercy Radio. Our special thanks to Dr. O'Connell for visiting with us today. If you missed any part of our program, you can play our past shows by going to catholic540am.org and clicking on local shows. The Executive Director of Divine Mercy Radio is Cecilia Flannery. Our Director of Programming is Peter K. O'Connell. Our engineer is Keith Flannery. I'm Ellen White. God bless.